Hello friends, in this video we'll briefly see a case of thoracoscopic right upper lobectomy in a 2.5 kg baby. The child was 50 day old boy who presented with respiratory distress which was significant, and the child had to be put on a ventilator. So this is the preoperative x-ray in which we can see a huge lesion in the right side which is compressing the right lung and also causing a mediastinal deviation and compression of the left lung. These are the Excel images showing the same finding. So patient was stabilized and taken up for surgery. We could not achieve a single lung ventilation. So this was a position lateral, and there were four ports that were used: one 2 3 mm and one 10 mm and one 5 mm. So the camera port is inserted as caudal as possible, as we can see in this image. So we are using another port camera through another port to see that the port is right above the diaphragm. And here is the cyst which is now partially compressed, and the first thing is that we do is to compress and deflate this cyst by using a sealer. So we are using a vessel sealer to compress this cyst. So after a couple of minutes the cyst has been totally compressed, and we can make out that it's rising from the lower surface of the right upper lobe. So we need to do a right upper lobectomy. So we are just at the apex of the fissure, and we can see. So the approach in thoracoscopy is usually to go to the bronchus first in these cases. So we're just creating a space here, and we can see there are some vessels here. So probably because of this cyst, the area was bit, the anatomy was rotated, and here probably what we can see after removing this lung tissue is the tributaries of the superior pulmonary vein that we usually encounter first if we go from the anterior side. But here, maybe because of rotation or some aberrant anatomy, it is there right over the area where we just over the area before we approach the bronchus. So these tributaries are then sealed and divided, not using a hemolong for these vessels. These are too small and can be managed with sealing. So using a biclamp now just to seal the device and then divide, and this is the last tributary that we could see, which has again been dissected and will be sealed and divided. One problem in tackling the vein first is that the arterial supply is still on and the lung becomes congested, and there's some oozing. As we can see, there's some degree of oozing, although there's no definite bleed, but there's oozing. Now this is the bronchus that we are dissecting right now. So the first thing that we usually expect if you go posteriorly is the bronchus. So this is the bronchus, and just anterior the bronchus we can see the pulmonary vessels, the artery, and if you're not careful you can easily damage these arteries. But you can see the view in thoracoscopy is amazing, and we can see these branches very easily. So going to the divisions of the bronchus so that I can apply a clip safely in this area. So after dissection, applying a hemolock, two hemolocks, and then we'll divide this bronchus, that's bronchus, and now we are dissecting the other division of bronchus, which is again clipped, and then it's divided. So you can again appreciate some degree of oozing which is there because the arterial supply is still on and the vein has been divided. So now we can see the branches of the pulmonary artery very clearly, which are again dissected and sealed again with the biclamp and then divided. Now this is probably the last branch, obvious branch, which is again sealed and divided, and this is the remaining tissue which is divided with this again a sealer. So last bit of tissue, this is all that remains to separate this right upper lobe, and this small degree of oozing was there that I mentioned, the only drawback of handling the vein first. So whatever remaining tissue is left, the strand is again sealed and divided. There was an artery, you can appreciate there was some pulsation in that, so that was a branch of the artery that was remaining, and that was again we put a hemolock and divided. Needless to say, we need to look for any air leak after that, and that was the X-ray. And thank you for your time.